It's 1 out of 8. You can imagine if you're having like 40 women, then 5 of them are expected to develop breast cancer. So that is it's a scary reality that we have to live with and face. Breast cancer accounts to up to 23.3% of all the cancer cases diagnosed in women. And it's the second leading cause of cancer-related deaths. The leading cancer-related deaths are from lung cancer. So breast cancer comes in number 2. So some breast cancer statistics. This is a mortality rates that were done in 2020. And we can see the shades for breast cancer in females aged 15 and above. You can see the shades of red. The deep red shows, is it deep red or dark red? Shows the areas that were mostly affected. And you can see the African continent is very much affected by this breast cancer. And why is it that the African continent is being affected so much than the other developed countries? This might be due to late-stage diagnosis, limited access to healthcare, high prevalence of diseases like HIV, or underreporting. Maybe the cancers are there, but they're not being reported. So we only report once the deaths have occurred. Another reason could be like socioeconomic factors, maybe like poverty, unhealthy lifestyles, like poor diet, not giving cancer the priority that it deserves. We know we are living in the African continent, the healthcare system is not given that much weight as it deserves. So it is a high time that we advocate for our leaders to see the need of giving the weight that healthcare system really deserves. So signs and symptoms of breast cancer. What will you be looking at or for when you are trying to diagnose breast cancer? The first one is a lump in the breast, nipple retraction, redness or pitting of the skin. They call it the orange-like skin. Abnormal nipple discharge. Abnormal, that means you're having a nipple discharge that is not normal. The normal discharge will either be clear fluid, maybe during pregnancy in preparation for lactation, or milk. So you're having a discharge from the nipple that is not normal, that is not either clear or it's not milk. So that means you need to go for checkup. Then we look for swollen axillary nodes, especially the sentinel nodes, the nodes that are the first one to be affected by in case there is a breast cancer. But keep in mind, not all lumps in the breast means that you have a breast cancer. There might be benign lumps. They might be cystic. So in case you see a lump, there's no need for you to get worried unless you have gone for treatment, for diagnosis. So these are some of the lumps that you will be expecting in women. In young women, especially less than 35 years, the most common lumps will be fibroadenomas. It's fibroadenoma, just a fatty tissue. These fibroadenomas that are normally associated with hormones. We know that age, especially the age in the 20s, early 30s, that's when the hormones in women are very active. So fibroadenomas will be very common in that age. Then you have the fibrocystic diseases. Galactocele is just like a cyst-like bug, and the content is normal, just milk. This one occurs in postpartum, especially during breastfeeding, and it's just as a result of a blocked duct. Maybe milk were being produced, but they could not find their way outside the breast. So they just accumulate in a sac-like bag called like galactocele. So this one, most of the management is simple. The client is just always advised to take antibiotics to avoid infections. And if you're breastfeeding, the mother is just allowed to continue breastfeeding as you do your antibiotics, or you can express the milk, just express. And as you express, you apply some warm compressants on the breast and the area. it will just release itself. Or if you have to go to the hospital, the moment they go inside to get an FNA with a needle, the content will just be milk. In women less than 35 years, carcinomas are very rare, but we cannot rule them out. They can still occur, but they're very rare. Then in older women, that is more than 50 years, the carcinoma are very common. So when you're having a lump in the breast, it's unlikely that it could be a fibroadenoma. It could be, but in most cases, they point towards carcinoma or cancerous or malignancy. Then they can also be having cysts, not really common. Then fibroadenomas, they can also occur. So what are the risk factors for breast cancer? Gender. The female gender, it's at high risk, with 99% of all breast cancer cases occurring in women. 99% they occur in women, which means there's that 1% that is remaining. Where does that 1% go? Of course, it affects men. So we cannot rule out breast cancer in men, especially the men with gynecomastia. We can't rule it out. So if you're a man and you feel there's a lump in your breast, kindly go for checkup. It's always advisable for you to go for checkup. It could be. We're not saying it will be, but it could be something for a cause for alarm. It could be cancer. And then age, as I've talked earlier, breast cancer, the risk of breast cancer increases with increase in age. It's very uncommon below 30 years. It does occur. Few cases does occur below 30, but the risk increases with increase in age. Parity. Parity is just the number of children that someone gets in their lifetime. They say that the more the children you get, the lesser the risk of breast cancer, because that aspect of breastfeeding, it decreases the risk of breast cancer. So, our dear ladies, if you get children, please let us breastfeed. Let's just breastfeed as much as you can, because it is a protective factor. It will decrease the risk of getting breast cancer. Then hormonal use, and especially this comes in because of the family planning methods that we are using. Most of the family planning methods are hormone-based, and somehow people have to use them. So the more you use those hormones, the more you are exposing your body to more hormones, and your body is also having hormones. So the hormones might reach a point whereby you will be experiencing hormonal imbalances, and they might even affect the cell, then the cell divisions, then progress to development of cancer. So I'm not saying that people should stop using family planning methods that are hormone-based, but if you can, minimize, because there is a breast cancer, a type of breast cancer that is hormonal sensitive, the ER/PR positive, that is estrogen receptor and progesterone receptor positive. That kind of breast cancer will always come around, especially mostly if you are exposed to a lot of hormones in your lifetime. Then we have the genetics, that is breast cancer history, family history. Of course, if there's a kin of yours that has had breast cancer before, there's a high probability that you're carrying these genes in your system, in your DNA. Then cigarette smoking. Cigarette smoking is normally associated with breast cancer because they say there are some carcinogens in the tobacco that lead to development of breast cancer. They make the cells to misbehave. So if you can, kindly, or you know someone who is fond of smoking, tell them to regulate it. They have to turn it down. This just trying to show what I'm explaining here. Then there's here diabetes. They say high insulin levels will make the cells to misbehave. Then exposure to radiations here. Then we have, this is pregnancy. Pregnancy, it is both, it can both increase the risk of breast cancer or decrease the risk of breast cancer. But in most cases, pregnancy, when the more times you get pregnant, it reduces the risk. It increases the risk because when someone is pregnant, especially the first trimester and partially the second trimester, the hormonal activity is very high, especially the estrogen and progesterone hormones. So they say that the hormone activity, when it's high, they might lead to over multiplication of the cells. But that is short term, it's short lived. Once you give birth and start breastfeeding, then that is taken care of. And we will always advocate for women to get babies, to get pregnant, because it is a protective factor for breast cancer, for so many issues. For breast cancer, it will protect you from other issues, even development of fibroids and so many other issues. So if you can get pregnant, and get babies and breastfeed. So breast cancer, how we diagnosing breast cancer? Just like any other cancer, we go the triple assessment way. That starts from the clinical assessment. But before we reach the clinical assessment, you as an individual, you are the first doctor of your own body. You are the person who is going to feel the lump in your breast. You're going to see if there's a discharge in your breast. From your breast, you're going to see if you have an ulcer, if your breast, the contours are changing, like the shape is changing. You're the first person who will be able to notice all those changes. If you're having swollen lymph nodes, you'll be able to notice all these changes. Then once you notice them, you go for checkup. Then when you go to the hospital, the first step is clinical assessment. The clinician will be there, listening to your history, your signs and symptoms. Then they'll examine you. They'll do the clinical assessment, checking, palpating the breast, checking the size of the lump, the location, the mobility, the tenderness, and all that. Then once the clinician has seen that the lump needs it's something that needs to be looked into, they'll recommend imaging. Most of the time, they'll send you for an ultrasound, especially for young women. For older women, mammography is always recommended. We are sending young women for ultrasound because we said young women, most of the lumps might be fibroadenomas. Sorry. So the imaging for ultrasound, it's recommended for young women, then the mammography for older women, because most of the time for older women, they just go looking for carcinomas if they are present. Then after imaging, during imaging, the breast imaging will be able to categorize. Using the breast virals, you're able to categorize the scan into several categories. And they can be from category 1 to category 6. The first, if you see it's category 1, your radiology report says it's category 1, then that is negative. And it means that you just need routine checkup. You have a lump, but from the ultrasound, it shows it's not cystic, it's not a fibroadenoma, it's not carcinoma, it's just like a prominence, like just a swelling. So they say it's negative. So from there, you just do routine checkup, because the likelihood of developing breast cancer is 0. If the ultrasound says it's category 2, that is benign, then it's just routine checkup, because the likelihood is actually 0. Category 3 will also be probably benign, probably because the likelihood for developing cancer will be more than 0, but less than 2%. So that one you do a follow-up, like after 6 months interval, you do after 6 months, then after 1 year, depending on how the doctor will recommend. If the bilates are category 4, then that is suspicious, and it means you have to go for an FNA. And that's category 4. If it's suspicious, can be low suspicious, whereby the risk is more than 2. The likelihood of developing breast cancer is more than 2, but less than 10. It can be moderate suspicious, whereby the likelihood is more than 10, but less than 50. Then it can be high suspicious, more than 50, but less than 95%. If it's category 5, if your bilateral comes to like C5, then that says it's highly suggestive, then you need to do a core biopsy right away because it's more than 95%. Category 6 is actually for non-breast cancer cases. Then from there, from the ultrasound, from the bilaterals, if it's less than 3, bilaterals 3, then that means you don't need to go for FNA, because that is just exposing the patient to more pain. But if it's more than 3, that is 4 and above, then you need to do an FNA. That's where you come in. Fine needle aspiration, cytology. And this one, just like the ultrasound, will also, based on the outcome of the FNA, it will also categorize the breast lump into 5 categories. Category 1, when it's category 1, C1, then that means it's inadequate. You just see the report, FNA report written, it's inadequate or non-diagnostic. When it's inadequate or non-diagnostic, that means that you have to repeat the FNA. The cytology has to be repeated for a proper diagnosis or screening to be made. If it's category 2, that means it's benign. And benign, it can be a fibroadenoma, and if it's a fibroadenoma, it can be like removed or just monitor. If it's category 3 or 4, those are category 3 or 4, 3 and 4, that is equivocal, means it's suspicious, it's borderline, it's somewhere there. So it means when it's C3 or stroke C4, it's equivocal or borderline. It means you have to go for tissue biopsy. And that's why you see the FNA, the cytology has helped you to screen, and it's telling you now this one needs to go to another stage. But if it's just like category 1 or 2, category 2 or 3, then you don't need, category 2 don't need to go for biopsy. But if it's category 3 or 4, tissue biopsy is always recommended. Do a core biopsy. If it's category 5, that means it's already known it's breast cancer. It's like already diagnosed. It's already known it's breast cancer. So that means you have to start planning the way forward for treatment. So this picture here is just trying to explain what I'm trying to say. You can see this is how you diagnose breast cancer. You have done the clinical assessment by the clinician. You have done the ultrasound or mammography there. Then you have done your FNA. Then your FNA is here. There's the
Tina, can you hear me? Tina? Tina?
Yes, I can hear you.
Okay, proceed.
Are you able to hear me?
We lost you, but you can proceed now.
On the same slide, or I go?
No, on the same slide.
Okay. So you can see this. I'm just trying to use this diagram to explain what I've been telling you. If it's category 2 and it's unsuspicious, maybe it's a fibroadenoma. Then if it's more than 35 years, that means you can go for excision. If it's less than 35 years, the patient is not concerned you can just make a follow-up depending on the size of the lump. If the patient is concerned, then you just go and remove it. Just a fibroadenoma, it's benign. Then if it's category 2 from FNA, but clinically, with category 2 means it's benign, but clinically or radiologically, it's suggestive for malignancy or it's suspicious, then you have to repeat the triple assessment. That is the imaging, the clinical assessment, and the FNA, you have to repeat it. Or another option, you have to go for a core biopsy. Then the core biopsy will be able to give a clear picture of what is happening. If it's category 3 or 4, that is equivocal borderline, that means you have to go for a core biopsy. Then if it's category 5, that means it is definitely carcinoma. It's malignant. But we are sorry, as much as it's already known it's a carcinoma, you cannot start treatment at this point unless you do a core biopsy. And this is because you will need the core biopsy. A core biopsy is needed for ancillary studies, that is immunohistochemistry, which cannot be done on FNA unless the person, the clinician, or the radiologist or the pathologist or the technologist who was doing the FNA had enough sample, got enough sample, and used some of the material to prepare a cell block. You can prepare a cell block from FNA, then you fix it, and then you process it as a core biopsy histologically. So if you have that sufficient material, then you don't have to go back to the patient for a core biopsy for you to do immunohistochemistry. You can do immunohistochemistry on the FNA material, but that is normally not the practice. Normally, that's not what we normally do. What we normally do, we just take enough material for FNA, then you prepare smears, and you are done. We normally don't keep other material for cell blocks. Maybe that is something that we can look at in future to avoid going to the patient for a more invasive procedure just to get a core biopsy to do immunohistochemistry. Why are you doing immunohistochemistry? Because you want to classify this breast cancer, you have to know the kind of treatment that this client has to get. For breast cancer, when you're doing immunohistochemistry, you normally do 4 markers. That is human epidermal growth factor receptor 2, commonly known as HER2, ER or estrogen receptor, PR or progesterone receptor, and then Ki67, that is for proliferation, for checking the proliferation index. So if it's HER2 positive, if it turns out to be HER2 positive, that means this particular client is going to get Herceptin as chemotherapy. If it's ER/PR positive, those are hormones. That means this particular client, when it comes to treatment, will be getting hormonal chemotherapy. I say Ki67, I said it's for proliferation index. So you can see after doing FNA, apparently we still have to go for core biopsy, for a biopsy, because we said biopsy is the gold standard. So, but it can be avoided if we get enough material for FNA and we are able to prepare cell blocks, then we preserve those cells in form of blocks. We can avoid the core biopsies. Then another lump that can be in the breast, and it can be a cyst. Then this cyst, when you go inside, most of the time when you go inside the cyst, if it's just a cyst, when you go inside with a needle doing an FNA, most of the time it will just collapse. Because the moment you go inside the needle, then you create a suction in the syringe, you are able to aspirate the fluid. That fluid, you can just take it to cytology lab. We can put them in the cuvettes. We balance the cuvettes in a cytospin. The cuvettes normally have a place for slide holding. So you just balance in the cytospin. you spin at 3,000 revolutions per minute for around 5 minutes, you'll be having your material on the slide. Some cells, just cells. This is cytology, so you're just harvesting cells from the fluid. So those cells, you fix them. And when you're fixing the cells, it's recommended that you don't put them direct, the slides direct in a fixative. You do you drop the fixative on top, the flooding form of fixation, so that you don't have to, when you to lose the cells when you're immersing the slide in the fixative. Just put a drop of the fixative, normal 95% alcohol, then let it fix. Then you can stain and you'll be having your results. So cytology. Cytology is just the study of cells to detect diseases. And why cytology? Why opt for cytology and not go straight away to core biopsies? Cytology is important in cancer screening and diagnosis. It helps in early detection and monitoring. And apart from just screening of cancer, cytology can also be used to identify infectious diseases like bacteria. You can just stain Zn in the lab, then on cytology smears, then you'll be able to see if you are having bacilli. Fungi. Cytology is very important in identification of fungi. Parasites. Cytology is also important because when this procedure exposes the patient to minimal trauma and pain. The pain you experience during an FNA procedure, it's very minimal compared to the pain that the patient is going to experience during a core biopsy. Cytology also helps to avoid more invasive procedure, that's the biopsy. When you're having a lump, it's always important that you go through the right channel of diagnosis or of screening, because that lump will just be a cyst. When you go for an FNA and just a cyst and the lump, the syringe is used to go inside, you'll just be able to aspirate the fluid and it's done. Don't have to go for a biopsy. Then cytology is a very quick procedure. It takes, for palpation guided FNA, it takes around 10 to 15 minutes and you're done taking the sample. And for ultrasound guided, it will take around 20 minutes and you're done with the procedure. Then you'll have taken the sample, you fix the sample, the slides, and after fixation, which takes around 30 minutes, you're able to stain your slides. And after staining your slides, you can examine them. So for cytology, for FNA, you can get your results within very minimal time, like even 2 hours of sample removal. So what are the samples that we receive in a cytology laboratory? We have the FNS, that is fine needle aspiration cytology, fine needle aspirates, which is very important in breast cancer screening and diagnosis, sorry. We'll be also receiving we also receive pap smears in cytology lab, body fluids like the CSF, pleural fluids, ascitic fluids, sputum, and then touch smears or imprint smears. And these touch smears can also even apply to breasts, because if you're having an ulcer on the breast, you can just take a slide, label it, then you touch, make an imprint smear on the slide, then you're able to fix the smear, and then you stain it, and you're able to examine and see what is wrong. So touch smears can also apply. So how do you prepare the client for an FNA procedure? The client will present themselves with a request form. Ask the client to say, just welcome the client, make them comfortable. Ask the client to say his or her name. If it's a minor, then the guardian can accompany him or her. Explain the procedure to the client. While explaining the procedure, what you're going to do, how you're going to do it, reassure the patient. Make sure, just explain to the client and make sure you reassure the patient that the procedure is not going to hurt. The pain will be minimal and it's manageable, and it's not going to be something to be worried about. Reassure the client. Once the client is comfortable, let them sign their consent form. After signing the consent form, attach that consent form to the request form. Then the client will lie on the procedure bed or just sits up, depending on the position of the lamp. The site of the FNA will be cleaned with a sterile solution. Spirit works well. Local anesthesia may be applied, maybe, but it's not necessary because you're just using the normal needle you use for blood drawing, for drawing blood. So it's not really necessary, but it can be applied. So this one is just trying to demonstrate. This is an ultrasound guided FNA. You can see the patient is lying there. They're using, ultrasound is using the sound waves to create images on the screen. So you can see where the breast, the lump in the breast is being visualized on the screen. And the doctor or the person performing the procedure, you can see they're directing the needle. They're just directing the needle here while they look at the screen to the lump. This one is very good for, is very efficient for very small lumps, and you cannot miss it because you'll be able to see where your needle is going. So the FNA procedure, you can use either manual palpation or image guidance, as the one you have just seen, to locate the lump. Then you use a needle, usually gauge 21 to 25. 23 is most preferred. Is used to make passes in the lump. That is, if it's a solid lump, you make several passes. If it's cystic, just do once and this fluid will be able to be aspirated. A syringe is used to create suction and withdraw cells or fluid. Then you remove the needle and apply pressure to stop bleeding. Then you apply appropriate dressing. Label at least 2 slides. Then make cell smears and fix immediately. You can, if you have more than 2 slides, you can leave 1 slide unfixed. You just make, I'll tell you why. You just make 2 slides, you fix them, at least 2, then you fix them immediately. But if you have an extra slide, kindly leave 1 slide unfixed. Then send to pathology, that is the cytology lab for analysis. You can see what is happening here. This is the cells have been drawn. Then there's a slide there. Those are the cells being put on the slide. Then you take another slide. Then you rub it on top of the slide with the material to make the smears. This is how the smears should look like. Then this is a fixative. They're being fixed immediately. Then you can discard your syringe and needle in the appropriate sharps container. So analysis of the material taken of the FNA that you have taken. How do you analyze them? Staining techniques that can be employed. Hematoxylin and eosin is the routine staining technique. That one is very routine. It has to be done. And for hematoxylin and eosin, you're using 2 principal stains, that is hematoxylin and eosin. After fixing the smears for minimum of 30 minutes, you just rinse in water. Then you stain in Harris hematoxylin for 3 minutes. Then rinse excess. From there, you differentiate in 0.05% acid alcohol. These are cells. That's why you can see even the staining time is less compared to when you're staining core, as in tissue sections. For cytology, you're just dealing with cells. And because they're delicate, just using stain, even the staining the staining time is reduced. And even the differentiator, here we are using 0.05% as a acid. But when you go to histology for biopsies, for tissue biopsies, we are using 1% acid alcohol. Here we are using 0.05% acid water. Then after differentiating, you rinse, then you blew in Scott's tap water. After that, you will counter stain in eosin for 1 minute, just 1 minute. Then you dehydrate, clear in xylene, mount, and your slides, you let them set, then they are ready for reporting. The extra slide that was fixed, you can you stain using Papanicolaou staining technique. And for Papanicolaou staining technique, again, after fixing for 30 minutes minimum, you rinse in water, stain in Harris hematoxylin for 4 minutes, rinse the excess. Then from there, you differentiate again in acid water, 0.05% acid water, rinse, blew in Scott's tap water. Then after blowing in Scott's tap water, you rinse in 95, for Papanicolaou, you rinse in 95% alcohol, 2 changes. Then from there, you stain in orange G for around 1 hour, for one minute, 30 seconds. Then again, you rinse in 95% alcohol. Then from there, you stain in eosin aza. This one, Papanicolaou has 2 counter stains. That's the orange G and then the eosin aza. Then you stain in eosin aza for around 3 minutes, dehydrate, then clear in xylene, and then mount. Again, the slide will be ready for, just let it to set, then it's ready for examination. If you have an extra slide, I said you prepare extra slide if you can, then you can do the diff quick. And diff quick, this one is the slide is normally air dried after collection. You air dry it, then you take to the lab, you'll fix with methanol. Then you stain using 2 stains. We use an eosinophilic stain that is red, and the basophilic stain that is blue. Mostly the field stain. I know you can remember the field stains. Field stain A and field stain B. Then after that, again you air dry, then you mount in DPX and your slide is ready. But this staining technique can also, the staining can also be done using an autostainer. If you have an autostainer, you don't have to go through the manual methods. You just set your autostainer, the jazz well, then you start the program. Then the slides will be able to stain. So how do we go about for doing QC in cytology? In cytology, we keep on filtering the stains regularly. You have to filter, keep on filtering to make sure the stain is clear or is free of any floaters. Then a blank slide is stained alone to check for floaters, for the presence of floaters, because especially if it's a busy cytology and you're using the same hematoxylin stain to stain both FNAs or both FNAs and pap smears. Pap smears, the material keep on like shedding off from the slides, because you can find some pap smears when they are taken. The material are so much. There are a lot. So when you're staining, some will just like shed off. So you have to you have to always check for floaters, because you might be checking for an FNA from the breast, then you are seeing the cells from the cervix, maybe for pap smear. So you have to check for floaters. So a blank slide is just stained alone. Just stain a blank slide. Then you examine if there are any floaters. Then an extra slide should be stained alone. If you have an extra slide, you stain it alone. Just fix it normally, then you stain it using H&E method to the end, and then examine for the quality of stains, because you might be checking for floaters and maybe your stain has deteriorated. It has been overused. So you have to check for the quality of staining. So just train one slide, then you check for the quality of stains, then you label it as QC, and then you archive it. During audits, when they ask you how you're doing your QCs in cytology, you produce those slides. You document with the documents. Then those are just images, the outcome of the staining results, FNS staining results. The first one, A, is the FNA results, H&E, and it's showing an invasive ductal carcinoma. It is invasive. You can see how the cells are looking like the background is barely visible. On my right is a benign breast lesion. Those are also just images that you'll be getting after staining. The first one, A, is a pap stain, an FNA, breast FNA, pap stain showing invasive ductal carcinoma. And then B is also an invasive ductal carcinoma stain using DIFF-QUIC. Thank you for listening.
Thank you, Tina. Thank you. That is wonderfully done and very clear. I love the pictorials. They're very nice. You must have taken a lot of time to prepare this. And I can see we have a couple of questions and comments. I know cytology or histology largely is an area that is not routinely practiced in our labs. And it's kind of forgotten in a way, but I want to thank you for bringing this to light. And maybe I can just read a few questions so that we can delve into the questions and comments. I'm not sure if there's any participant who wants to talk or who wants to make a verbal comment. But in case there is, just raise your hand. I will be able to allow you. Ian, I can see your hand. I'm hoping you want to make your comment. Ian and John, if not, you can have your hands down. So if not, you can have your hands down, but I can start with the questions and the concerns. I can see a couple of them. I'm hoping we shall be able to discuss. First of all, Tina, a lot of messages that are thanking you for this presentation. Mwagonga Chiponda says it's a good presentation. There's someone who's anonymous is saying that a very good presentation is bringing histology and cytology back to the memories. I think I've said that many of our hospitals don't routinely practice this. And maybe I can get this question from Benedict Wachala.
Okay.
After how long will the FNA be able to tell if someone has breast cancer? Okay, I'll read them as they are, and you can also write just the way you want to write, but I'll just read that. Maybe Tina, you can just try and understand what he's trying to ask. After how long will the FNA be able to tell if someone has breast cancer? That's the time from. I think that's exactly how he has written.
Mm-hmm.
Yeah, so after how long will the FNA be able to tell if someone has breast cancer?
I respond to that first.
Yes.
Okay, as we have said, breast cancer is cancer goes through a series of the assessment. We have the triple assessment. First, we cannot tell you have breast cancer unless you present yourself. You have to come forward, and someone has to come forward and say they present themselves with the symptoms. We shall be able to tell. They should be able to tell. The client should be able to tell how long the lump has been there, because it's the client who has been having the lump. So you come and say, maybe I have been having a lump for like 3 months or 1 year or 2 years, depending. But we always advocate for routine screening. If you go for routine screening, we'll be able to pick the lumps early. So if the client comes and says I've been having this lump for 3 months or for 1 year, the course of diagnosis then starts from there. The doctor will just examine, then the doctor will send you for imaging. They normally start with imaging most of the time. Then based on the imaging report, then the doctor will be able to decide if an FNA is necessary. Then that's when the FNA comes in. And I've said, as I've said, the FNA will be able to categorize your lump into 5 categories. The C1, C2, C3, C4, C5, depending on what we see. So if it's like C2, then it's benign, then you have to go and to continue with the routine. If it's C3 or C4, equivocal, it's there in the middle, so you have to go for a biopsy or you have to repeat. But if it's C5, then it's definitely breast cancer. So this one, after how long, it will tell after how long that client has had that lump, then decided to come forward. And we have, as we saw in the statistics, most people, and they're not they don't have access to these screening programs. And that's why they don't go early enough. But if someone can be able to present early enough, the course of diagnosis, the process of diagnosis starts from there. I hope that can help.
Thank you. We have a couple of questions, so we'll just see how to go about them. So okay. I'll read this from, maybe I can just read this from, okay. Maybe I can read this. McNodal Onyango. I'm not sure if Tina, we can repeat that. Kindly repeat for me the procedure of Papa Nicolau staining method.
Papa Nicolau staining method. Okay, I'll try to be slow. During that time, I was trying to beat time. So Papa Nicolau staining technique has 3 principal stains. That is the hematoxylin. Then that is the primary stain, the cytoplasmic stain. Then the nuclear stain, staining the nucleus. Then we have 2 counter stains. We have the orange G and we have the eosine aza. So once you fix your slide, after the slide is fixed, and you are doing Papa Nicolau staining technique, you start with, you rinse in water, then you stain in hematoxylin. 4 minutes. Just 4 minutes will be sufficient. Then after that, you rinse the excess. After rinsing the excess in water, you differentiate in 0.05% acid water. You just prepare 0.05% acid water as your differentiator. And I said here, you need a mild differentiator because you're just dealing with cells. So you differentiate just 1 dip, like 2 changes of 0.05%, just 1 dip in each, then you rinse. Then after there, you have to blue your cells. You have to blue your cells, and you are bluing using Scott's tap water. I hope you know how to prepare, the person knows how to prepare Scott's tap water, just using sodium bicarbonate and magnesium sulfate. Sodium bicarbonate, sodium bicarbonate is 3.5% grams per liter. Then magnesium sulfate, 20 grams per liter. Then you just, that will be your bluing solution. You can preserve it using thymol. Then after you have differentiated, you have to blue your slides. And that is your bluing solution using Scott's tap water. That one you just examine macroscopically. The moment you see the slides turning bluish, you remove the slides from the bluing solution. Then you rinse. In 95, you just transfer don't go back to water. Just you rinse in 95% alcohol. 2 changes. Then from there, you go to the first counter stain, that is the orange G. Then from the orange G, the orange G is 1.5 minutes. That's 1 hour, 1 minute, 30 seconds. Then from there, you rinse again in 95% alcohol. Then from there, you transfer the slides to eosin aza, 3 minutes. The time you are staining in eosin aza is double the time you stained in orange G. So if in orange G you had 1.5 minutes, that's 1 hour 30 seconds, then eosin aza you do 3 minutes. After that, you differentiate. You do differentiate in ascending grades of alcohol. Then from there, so starting from 70. Then from there, you clear in xylene. After clearing xylene, you will mount your slides and you're done.
Thank you, Tina. That was wonderful.
Okay.
I'll read. There's still a couple more. Achieng. Achieng is asking, is it true that sucking of breasts by men can reduce breast cancer?
Okay. What are men sucking? Okay. It depends, because when you're sucking the breast, you should be removing something. The kids will suck the breast to get milk, and that now becomes a protective effect. But if a man is sucking the breast and there's milk, as in there's a fluid being produced, there's milk being produced, I'm sorry, but I heard of a theory, I don't know if it's a theory or if it's a story of someone who, after giving birth, one breast is for the baby and the other one is for the man. So if it's in that case, then it's fine. It will reduce the risk.
Thank you. I'll read a couple more. Okay, Emmanuel Barasa, why is breast cancer more common in women than men?
Gender and because anatomically the female gender, we are designed to have breasts like big, as in the mammary glands. We are designed to, and it's all because of the hormones in women.
Okay, thank you, Tina. Expound on bilateral, this is Edward Leposo. Expound on bilateral mastectomy in the event when only one breast has a lump.
Bilateral mastectomy is whereby both breasts are being removed. If one breast is having a lump, one breast has a lump, then the clinician or the physicians handling the clients, they have seen the need, or they have seen the risk of this particular breast and particular cancer spreading to the other breast. In case they see that risk, there should be a risk somewhere. They can see it. There's a risk, especially if it's an invasive type of carcinoma. If they see the risk of the breast, of the cancer spreading to the other breast, then in that event, they will, with the consent of the client, decide whether to remove both breasts. But in most of the cases, they'll deal with the affected breast first.
Thank you, Tina. That's clear. I'll read two, so maybe you can just see. Andrew Kakanja, the difference between histology and cytology. And then Lorna Koskei, if you are living with an active smoker as a passive smoker, will you contract breast cancer?
Histology, from the word histo. Histo means tissues. So histology is the study of tissues. You're dealing with tissues. Cytology, cyto means cells. So cytology is the study of cells. So in cytology, you're just going for cells. Histology, you're going for the entire tissue, in the tissue, including the cells. Yeah. Then, if you're living with an active smoker, as a passive smoker, the risk is there, but not as much as the person, the primary smoker. It's not like you'll contract breast cancer, no. But the risk is there because you are a passive smoker. You are being exposed to those fumes, those carcinogens from the smoke.
Thank you, Tina. I'll read again two more. From Biko Omondi. Could you kindly clarify on the downside of dipping the slides in a fixative over the preferred flooding? And then the second one from Susan Karaoke. Are MLS allowed to perform FNA, or is it the job of a pathologist?
For the slides, fixation of slides, that was the first one, right?
Yes.
The fixation of slides, if you're having cells that the materials that if you perform a normal FNA, then you just dip the slides in the fixative, there's no harm. But for the flooding method comes in when you are dealing with very minimal material, like when you're having fluid, like imagine dealing with a CSF. A CSF is very clear, it's like water. So if you dip it in a fixative, definitely it clears off. It clears off. There's nothing left on the slide. So that's why after cytospin, after spinning in a cytospin, for the fluids, we recommend the flooding method so that you can at least try to preserve all the cells that you're having on the slide. But for the conventional FNA, the normal FNA that is done, you remove the material using the needle and the syringe, then you put on the slide, then you prepare. You just fix in the fixative using the emulsion. There's no harm. That one it will not wash away. The second question was, whether technologies can perform FNAs.
Yes.
Yes, dear, you can if you have done cytology, masters in cytology or clinical cytology and histopathology, and you are working in a resource limited area, like in the remote where we don't have a pathologist. You will do the FNA. Just do the FNA, fix the slide. It's allowed.
Thank you. I'll read a couple more. Can see very many questions, team. I think you are very attentive and we welcome them. So this is Irene Morumbi. If there is a mass and it has no pain, okay, I don't know, but I'll just read the way it is. Tina, you can just try and understand. If there is a mass and has no pain, must be removed. If yes, where can you advise one to go for the removal? Okay. I think she's saying if one has a mass.
I get it.
Okay.
I get it. Most of the cancerous tumors, actually, they are painless. They are painless. Most of them, they are painless. So, and you cannot say that it is breast cancer unless you have gone for checkup. So the most appropriate advice is for the affected person to go to be checked. Even for the clinical assessment, even for just palpation, you can go, even for a clinical officer can do that, any facility, and they'll be able to make a decision whether you need to go for imaging or to do an FNA. Most of the time, people bypass the imaging aspect because of the resources. So after the mass has been seen, then they recommend an FNA, but it's a shortcut, though not appropriate, because you might be going for an FNA for something that is not even to be worried about. But any mass, don't ignore it. Go for checkup. Go to any facility. Anyone,
Thank you.
any medical officer will be able to attend to you.
Thank you, Tina. Duncan Murithi, thank you for your question. How can one differentiate between a benign tumor and a malignant tumor after staining? Then, can benign tumor be cancerous later?
After staining, after looking under the microscope, you look under the microscope, then you look at the cells, how the cells are appearing. For benign tumors, you'll see the cells will just be normal. The cytoplasm, the nuclear cytoplasm ratio will be normal. The staining will be normal. But when it's a cancerous cell, you will see so many, irregular shaped nucleus, anisokaryosis, the margins will be irregular. You'll see so many prominent nucleoli. Yeah, you'll be able to see a malignant tumor. You just be looking at a malignant tumor. So long as you're able to know the normal cell, you'll be able to know when the cell is not normal, how it is staining, staining properties, the size of the nucleus, the shape. Yeah.
Thank you, Tina.
Okay.
Now Peter asks, which fixative is used to fix the FNA?
95% alcohol.
Thank you. From the last slides you have shown, this is Lucas Momo. How can you identify cancer cells?
Okay. I didn't get a slide that was normal. You would have seen a normal slide from the cancerous slide, but let's just look at the slides. Let's look at this one. A normal cell, the nucleus is supposed to be a third of this entire cell, like a third, like the nuclear cytoplasm ratio. The nucleus should be like it should be small, like a third of the cell. But when you see this one, look at this. Let's look at this one. This cell, you can barely see the cytoplasm. It's not even there. Then you can see how the staining property, how they are, the hyperchromasia. You can see the sizes of the shapes of the contours of the nucleus of the cells. These are the nucleus. You can see they are irregular in shape. Different sizes. You can see you have big ones, you have small ones. We have this one deeply staining. The nucleoli is so prominent. You can see there. Then this one, this is a benign one. The one on my right, B, this is a benign one. When you look compared to this one, you are able to see the cells, the nucleus are there. You can see the background so well. The cells are just normal there. But this one, you look at them, you'll see different sizes, different shapes. Then you can barely see the background. It's like, we said it's invasive. It's like it's investing into the background. So it has like eating up the background. You can see how they look like. Yeah. Next.
I'll read 3 more. Maybe you can be able to capture this. Which breast has the highest percentage of breast cancer, and which part specifically? That is from Maureen Sirengo. Which breast has the highest percentage of breast cancer, and which part? Irene Jebleki. Does the lump on the breast movable in case it is cancerous? Does the lump on the breast movable in case it is cancerous? And then the final one, what are the trigger factors from Hossein Abdi in the 1% males? Maybe you can answer those 3.
Which breast? From theory, from books, the left breast seems to be mostly affected. And that's why it's assumed, or that's why it has it's assumed to have more mass. I'm sure, ladies, if you examine ourselves, you are able to tell there's always that one breast that is bigger than the other one. And in most cases, it's normally the left breast. So from books, the left breast is said to have a higher percentage of, a higher risk of getting of developing cancer, the left breast. Then lump mobility, if the lump is movable or not. In most cases, when the lump is cancerous, it's non-mobile. It's not mobile. In most cases, it doesn't move. As a lump that is moving, mostly it will mostly be a cyst. But the one that is likely to be cancer doesn't move. They just, immobile. Then the 1% men. That was the last question, yeah?
Yes.
The 1% men that are likely to develop breast cancer. It happens, especially those that are likely to have, they say gynecomastia. They have their breast mass is slightly more than the one that is expected, like for normal men. Some men will opt for the breast breast reduction, for the mass. Okay, I've seen men coming for breast reduction, the one that have that because of the fear of developing breast cancer. So it's normally about hormones. It's hormonal related. Yeah.
Thank you, Tina.
You're welcome.
Caroline Nyawa, there's still many, but we shall just do with one we will manage. Can you infect your child during breastfeeding if the breast is infected? And then Rukia Abdullahi, kindly can I know where the lymph node for the breast is located? Those two? You take those two first.
If you can infect your child if the breast is infected. I think the person who has the breast, the question is not referring to breast cancer. I think it's for other conditions that occur during breastfeeding, like the galactosils, and mastitis. As I mentioned, if you're having a breast lump and you're breastfeeding, in most cases, it's unlikely to be cancer. It's unlikely, it can be, but it's unlikely to be cancer. So as you go for checkup, kindly take antibiotics, just because milk, even milk when it's still inside the body and it's being localized in one place, it can become infective. So for you not to pass the infection, just take antibiotics, but continue breastfeeding to relieve the breast. But if this particular client has breast cancer that has been already diagnosed breast cancer, and you get a baby, the clinician or the doctor or the gynecologist will be able to advise accordingly, depending on the kind of treatment that was the client has undergone before.
Thank you, Tina. I'll pick two more questions. And one is from Kanyivia Silas. You said, if possible, prepare more than 2 slides. In case you have 3, fix 2 and leave 1 unfixed.
Yes.
What is the reason? And then I'll bring in the other one from Bernard Kiboigo. What causes poor quality staining? You can take those 2.
The unfixed slide that I said, if possible, leave 1 unfixed. You'll do the 2 slides. You're going to do H&E, 1 slide, then Papa Nicolau staining technique, another slide. Then the unfixed slide, if you're able to do diff quick, you'll do diff quick. If you're not able to do diff quick, then use that particular slide as your control slide. if it was not fixed, do diff quick. If it was fixed, then do quality control with it. And even if it was not fixed and you're not able to do diff quick, then once you reach the lab, you can hydrate the slide. You are allowed to hydrate. You can still hydrate the slide using normal saline. It will, you hydrate the cells using normal saline. Just take the slide, dip it in normal saline. Then after that, you fix. Now, fix using the 95% alcohol, then use it as your quality control slide. The other question, I missed it.
Poor staining.
Oh.
What was staining?
Poor staining. It could be so many reasons that can lead to poor staining quality. It's poor stained slides. One, maybe your reagents are not, they have deteriorated. So that's why you have to do quality control to make sure that your reagents are in check. They're still of good quality. Another thing could be an improper fixation of the slides. Maybe the cells were not properly fixed. So make sure you fix the slide for a minimum of 30 minutes. Make sure the slides are well fixed. Then make sure all the reagents are of good quality. Then make sure you follow the standard operating procedure, the SOP. Then you'll be having good slides, quality stain.
Thank you. Noah Kihoro, kindly elaborate on parity, risk for breast cancer.
Parity is the number of kids a woman gets in her lifetime. We said the more children you get, the lesser the risk of developing breast cancer. Because one, there are several reasons. One, it's because when you get more children and you're breastfeeding, the aspect of breastfeeding makes your cells to continue differentiating. And we know, as in, they'll continue differentiating. And that one will always protect you. Okay, it will not like protect you, but it will decrease the risk of developing breast cancer. And that's why we are always advised to breastfeed like as much as you can. And just to give an example, like women from northeastern women, you can see them even in the videos, as in the how they breastfeed their children, like as in they breastfeed and they even don't put on most of them don't put on bras. Like they leave their breast freely, their breasts are breathing freely, and they breastfeed their children as much as they can. And it's very rare for them for you to get breast cancer in such people. So it's just a protective aspect. It decreases the risk the more children you get. And they say when you don't get children, especially if you don't get children when you're young, then your cells, the breast cells, might not like differentiate fully. You see? So if they are, and again, another thing is about the hormones. The estrogen and progesterone hormones, you know, they play a very important role in the life of a woman. So the moment you get pregnant, during that period for the 9 months, and even postpartum when you're breastfeeding, you'll find that most of the ladies, they're not having their periods during that time. Those hormones, they are kind of regulated during that time, rather than always having being in action throughout the lifetime. So, and you have seen we have a breast cancer type that is hormone sensitive. So get babies if you can. That's my advice. It will decrease the risk.
Thank you. We still have a couple, so maybe we can just try and cover a few. Gerald Ouda, thanks, Doc, for the wonderful presentation. I once did an FNA from a female patient, and the report came back showing tapeworm. What could be the possible cause?
FNA from breast.
Let me read this one from Rita Cherono. Is itching of the nipple a sign of breast cancer? Maybe you can try and answer them.
FNA from the breast tape. Okay, I'm not sure if it's an FNA from the breast, but as we have said, cytology is very important in the diagnosis. Apart from diagnosis, screening and diagnosis of cancers, it's also important in the identification of infectious diseases, and parasites are one of them. So it's not exclusive. The second question is about?
Itching nipples.
Oh, itching. No, it's not. It's not, unless the nipple is retracting. But itchy nipples, especially, this is just most of the time people experience this, especially maybe during ovulation or when they're about to have their periods. So it's not.
Okay, I can read a couple more. Sebastian Ojiambo, thank you. Why do you go for an ultrasound guide? FNA in younger women, whereas mammography in older women.
We've said ultrasound, it's recommended for younger women because in younger women, the risk of cancer is low, it's minimal. Especially, it's very uncommon below 30. It does occur, but it's very uncommon. So most of the time you're actually just looking, maybe fibroadenomas, the benign lumps or cysts. But for mammography, it's recommended for older women, because if you get a woman who is above 50 years and they're having a lump in the breast, that lump is just suspicious. And we know mammography it looks for carcinoma, as if for cancer. It's just looking for cancer. It's mammography just looking for, yeah.
That's clear. So I'll still bring a couple more. So this is from Nancy Mose. I have a mother who is 60 years old, and she has been having a lump since she was born, and it's not growing. Is there a need for FNA? And then Vincent Mutuku, how do imaging techniques like mammography, ultrasound, and MRI compare in sensitivity and specificity for breast cancer detection?
For the client, for the mother who is above 60 with a lump, let them go for checkup. Since she was born, let them just go for checkup. Some benign tumors, some lumps can start as benign. Then with time, they might, not always, but they might progress to become malignant. So let them go for a checkup. Then for the sensitivity and specificity for mammography and ultrasound or imaging, the sensitivity for tumors for mammography and imaging, we cannot say it's 100%, but it's above 65%. So once you're having, that's why after you've done an ultrasound or a mammogram, the ultrasound has categorized your lump as either benign. If it's benign, then it's benign. Then you don't have to go for further invasive procedures. But it will tell you it's quite sensitive, but not like 100%. It's above 65%.
Thank you, Tina. That's clear. We still have many more, but we shall just cover. Paul Odongo. Okay. Hi, my left breast is slightly bumpy than the right one for the last 20 plus years and slightly painful. Am I a candidate for breast cancer screening? And then I'll read from Lawi Mwangome. Highlight on automated cytological techniques. and comment on the new advancement in cytology. I'm Lawi Mwangome from Garissa County Referral Hospital. Thank you, Lawi.
Okay. For the left breast that is bumpy, if it's okay, let them go for checkup. Maybe it might be just a case of gynecomastia, just the enlargement of the breast, which occurs which is normal in men. But if it's something that is giving them, if it's something that is giving you some concern, then just go and rule out. Just go and roll out. Just go and see what it really is. Don't just sit there and continue having like doubts. When you go there, when you go to be assessed, they'll be able to tell you if it's something to worry about or not. Then automation in cytology. Most of the time, cytology is a very simple, it has very simple procedures, and most of the time you're just having you can stain using an autostainer, because cytology, once you take the samples from the patient going to the lab, there's not much like processing unless it's a fluid, and a fluid you just use a cytospin to spin. You just have your cytospin and you have your cuvette, so you just spin. After spinning, you are able to load your slides in an autostainer, and yes, this autostainer will do the staining for you. Then after staining, if it's for the advancement, you can use imaging. You can use the image. You can just there's a machine that is able to read this, is able to scan the slides and send the images on the screen. Then you can report it from wherever you are, whether it's a cytologist or a pathologist, wherever they are, whether it's in Mombasa and you're screening from Nairobi, they're able to report. And
thank you, Tina.
Okay.
Thank you. Maybe we can just pick these 3 questions, the quick ones. Beatrice Ndongo, can you stain GEMSA on the unfixed slides?
Yes, you can.
Okay. Peter Murray, can any hard lump in the chest mean cancer?
Sorry?
Lump. Can any hard lump in the chest mean cancer?
No, it doesn't. And a solid lump in the breast, it doesn't mean it's cancer. You have to go for checkup first, because apart from the cysts that are normally mobile, even the fibroadenomas, they are solid masses. So you have to go for checkup for you to know if whether it's cancer or not. You cannot tell by just feeling by your own hand. You will be able to know that they have a lump in the breast and it's not mobile, but you'll not be able to tell whether it's cancer. So you have to go for screening.
Thank you. Eric Siongi, what's the difference between a lymph node and a lump?
Lymph nodes. A lump, okay, lymph nodes are normally there. Generally, they are in the system. They only become swollen when they're trying to protect you from they are trying to fight infections. They're in the lymphatic systems. That's why it's the lymph node. And you know, one of the role of the lymphatic system is to protect us from infections. So they're trying to fight infections. So once there's like something abnormal, it's like affecting the immune system, then they'll try to react. And by reacting, it's by they become swollen. So you'll be able, and the first lymph node that becomes swollen or it's or becomes affected by cancer, it's called a sentinel lymph node. Some might be just be swelling because they're trying to affect, not to affect, they're trying to fight the infection, but they don't really mean that they are affected. So that's why if someone is having swollen lymph nodes, you have a breast lump and then you have swollen lymph nodes, or the lump could even be deep-rooted. It's inside there. not easily felt, but you will start feeling lymph nodes swelling in the axillary. That they are normally the lymph node that normally, most of the time that normally affected are in the armpits. So when you start feeling the lymph nodes are swelling, they might be affected, or they might be just be reacting in the process of trying to fight the infection.
Thank you. Maybe I can read a couple more, since there are a lot of concerns. Mutuania Paul Mwenda, can there be breast cancer without the occurrence of a lump on the breast? Tobias Yatich, does it mean that ultrasound is the gold standard method for diagnosis of breast cancer? Can you take those two?
Yes, it's true that a breast lump, breast cancer can be present in the absence of lumps, because these are some of the signs and symptoms of breast cancer. The most common, of course, it's a lump, but you have others. You can be having a nipple that is retracting. Maybe the cancer is there, but it's not like the tumor. The lump is very minute, but it's the invasive type. Maybe it's just spreading inside there, but it's very small. By the breast lumps, most of the times they're not so big. So it might be very small, and it might be in an area that you cannot feel with your bare hand. But you'll see other signs, you'll be seeing other signs and symptoms. Like you see the nipple is starting to retract, going inside, or having irregular shape. The breast itself, you'll see it becoming like the skin of an orange, very hard. You're not breastfeeding, but the breast starts becoming so hard itself. But when it's that hard, even trying to press, you're not able to feel the lump. You might be having abnormal discharge, especially when it's bloody, or you just start feeling the lymph nodes being swollen. So that breast cancer does not necessarily, you don't have to necessarily have to feel a lump in the breast. You might look out for other symptoms. Then ultrasound is not the gold standard. I remember I mentioned tissue biopsy is the gold standard. Ultrasound is just a screening method. It's just a screening method. It's just able to categorize using the birads, and then just able to categorize the breast, whether it's benign or it's suspicious. But ultrasound is not the gold standard. That's why you are sent for ultrasound to just see if it's something to worry about or it's something benign. It's just a screening method. A screening method for breast cancer, but it's not the gold standard, because you might, in some cases, this ultrasound can be bypassed. You just go for clinical assessment, then from there you go for an FNA. You're trying actually to save resources for this particular client. And they say they don't have money, they can't, you can bypass ultrasound. It's a shortcut, but you will be exposing the client to more pain, maybe when it's not necessary. Like for instance, if it's just a galactosile, you don't need to even go for an for FNA. If it's something that is less than 2, category 2, you don't need to go for an FNA, because
Thank you. Yeah, maybe Dikaya Alio, a lump that appears and disappears after a while and then reappears. Do cancer lumps have such characteristics?
Some do. Some do. Some will appear that way. But mostly when it's appearing and disappearing, those are just the issues with hormonal imbalances. There's a time when the hormones are, they'll just allow the lumps to be there. And there are times when they're not there. So those are issues with the hormones, but rarely does the breast lump appear and disappear, but some do. You
Thank
might
you.
say that I felt something here, but tomorrow I'm not feeling it. Maybe especially when it's in the initial stages.
Thank you. Maybe I can read the last ones because I've seen many questions revolving around this, Tina. Faith Kaki, thank you so much for the wonderful presentation, Doc. Is it true that family planning methods are predisposing factors to breast cancer? And if yes, what is the best that doesn't cause cancers? I think this question has been asked by many of you here on the best method. Tina, if you have any insights.
I think I mentioned that most of the hormonal based family planning methods, they are risk factors for breast cancer. When you're using hormonal based, especially most of the family planning methods are hormonal based, by the way, the pill, the depot, the Jadel. We have an IUCD that is hormonal based, the Mirena. All those are hormonal based, but you have the IUCD that is non-hormonal. We have the IUCD that is non-hormonal, though it has its own side effects, but it's better. If you can avoid it, just avoid it, the hormones, because as you have seen, there is a breast cancer type that is hormonal sensitive, the PR positive. So if you have that risk, then you are again exposing your body to more hormones, then you might trigger the things. So if you can avoid it, you go for the IUCD that is non-hormonal, if you can.
Thank you, Tina, and all participants. I think we have overstretched a bit, but I think it's for the benefit of the listeners and those who are in this webinar. So on behalf of all the participants, the very good comments, Isaiah Odote, this lady is thoroughly informed, good job and presentation.
Thank you.
Okay, bring us such comrades, and then maybe I'll read the final one from one saying, excellent presentation, Tina, you are my mentor at KNH. I'm Lina Kiptun.
Thank you.
Lina, it's overwhelming, and we have come to the end of our today's presentation. And maybe to you, Tina, you can say your final words before we bring this to a close.
Thank you, Fred. It's been quite an interactive session, but I'm happy. Yeah. Thank you.
Thank you so much. So I want to take this opportunity on behalf of LMSK to say thank you, Tina, for finding time and for also preparing a very thorough presentation, as we have seen with the pictorials and well explained. Thank you so much. And on behalf of all the participants who were able to log in, we were very many of us here, and we are very glad. We don't take it for granted. We want to say thank you, and we hope to interact and have more of these sessions even in the future, so that we are able to share on our best practices and also to improve our practice wherever we are. Otherwise, on behalf of all of us, this presentation was broadcasted live on our YouTube page. You can always go there and just for your own archive and knowledge, just go through. Otherwise, we want to say thank you, and we shall proceed to do some small quality assurance and transmit names of those who merit to KMLTB so that you are able to get your 3 CPD points. Otherwise, thank you so much. Until next time. Bye-bye.